Ladies and gentlemen, back again, this time chapter 13, chapter 14, trauma radiography, regardless of which chapter it is. Might have to update that, we'll have to see. But trauma radiography, it's fun, but it's also tragic. So it's fun for the x-ray tech because you get to do some unorthodox views, you get to think a little bit, get to adapt and overcome and figure out. It's kind of like solving a puzzle each and every time. Figure out how is it you're going to get this projection when the patient can't do this or the patient can't do that. That's the essence, that's the spirit of the exercise. Let's get into it. So there is a format, there's a definition of trauma, but there's also a format or a protocol or like some guidelines that you follow when you engage in trauma radiography. Couple rules that you have to abide by, more like a framework that you're trying to fit. And so we'll talk about that framework. We'll talk about how we all know there's three elements to an x-ray projection. You need an x-ray tube, you need a patient's body part, and then you need an image receptor on the other side. And we know that x-rays travel in straight lines, so those objects A, B, and C, as we learned last fall, A, B, and C have to be in a straight line. Otherwise, you're not going to catch the x-rays out the other end of the patient. So A is the x-ray tube, B is the body part, C is the image receptor. And most of our positioning that we've been taught so far is you have to push and pull and twist and rotate and communicate with your patient, obviously, but you have to manipulate the part into a certain arrangement so that it demonstrates the anatomy nicely. And if you don't get it just right, well, then you have to repeat it because it's non-diagnostic. So trauma presents a challenge in that you have to get the anatomy to display just right, but we can't manipulate the anatomy because the severity of the injury is such that manipulation would make it more unstable or exacerbate the condition of the patient and make the trauma worse. And so it's the special challenge of trauma radiography. Okay? We will have image critique at the end of this, referencing pertinent anatomy. I've got some slides added to the end where I just talk about certain trauma views that come up, and when I see that stuff, it'll be like, okay, how did I handle this? When does this situation come up? How is this better than some other method, so on and so forth. So I'll just talk about the various common trauma x-rays that you see. And we got a little movie for you. Let's see if this will play. Legendary director Quentin Tarantino, ladies and gentlemen.
There's a horse in my parking space.
Why are you riding a horse?
It's not mine, Rolando.
Oh, would I call security about that?
I don't know. That's why they pay you the big bucks.
Wait, Dr. Ross? 8 little Ranger Scouts, diarrhea, mucho. Which is why they pay you the big bucks.
Josh got up early. Let me sleep in. Our mothers are coming for brunch. He was going to clean the kitchen, bathroom.
Was he unconscious when you found him?
Yes, he mixed ammonia with bleach. I thought he'd know not to do that.
Okay, we'll take care of him. Let's get him in here.
Bleach. That's
You're going to have to stay out here.
Michelle.
We'll take care of him, okay? 3, 1, 2, 3. Wheezing.
Oh, 2 10 liters.
Nebulizer? Yeah, I'm giving 125 milligrams sodium Medrol IV push. When we call radiologists, get a portable chest film.
You got it.
BP's going nowhere. Still 50 over 30.
Carter, should we yank it? No, not
Gonna need a Foley.
All right.
How much
4 units. You'll work for explanatory laparotomy. Right again.
My son James, is he going to be okay?
I'm Dr. Hicks, Mrs. Schaefer. I don't know yet, but we'll do everything we can. Please wait out here. What have we got, Peter?
15-year-old male impaled on a rebound. We need to get him up to the OR for an X-lab.
Go on, Leslie's up there. He'll take him.
Anesthesia. Carter, come on. You're going with me.
Oh, let's keep it. Watch that lead. Hold it.
All right, clear the hallway. Let's get the elevator. Let's move. Go.
Claire, get out the way. Let's move.
Heads up. Look out.
Nice corsage.
My kids' Mother's Day. Shooting!
X-ray
Need
tech
any
trying
help?
to spot.
No, got
Oh,
it
that's an
under
old
control.
unit. That's an AMX3.
Fluorine gas
ladies and
poisoning.
gentlemen.
He's on humidified oxygen. 15 liters per
And that
minute. Give him
looks
sodium
like
medrol.
film.
125
Wow.
milligrams
This
IV.
is an old clip.
Respiratory's coming down.
Call me if you need anything. Drop blood gas.
Hold down for that.
Right. So that's ER. Yeah. So the definition of trauma. Man, I hope that video played. Definition of trauma is a sudden, unexpected, dramatic, forceful, or violent event. Blunt, penetrating, explosive, thermo. Those are common causes of traumatic injuries. Okay. So traumatic injury is always acute and always aggressive. Not necessarily life-threatening, but definitely serious. Okay. Lots of trauma is life-threatening, but there is some trauma that is not life-threatening, like a broken ankle is trauma, but it's not life-threatening. Okay. Burns over 90% of your body is trauma, and it is life-threatening. So the life-threatening part, how much is the patient's health compromised? Are they in a dangerous situation where they might lose their life, where they might pass on? It really depends on the specific scenario. Trauma is not always life-threatening. Trauma is always aggressively damaged tissues and organs and things of that nature. So wherever trauma manifests, it is an aggressive injury, and the tissue, the body part, what have you, is unstable. That's typically the key. That's why trauma radiography, you have to not manipulate if you can, because the tissue or the organ or the body part is unstable after the trauma has manifested. Right, so if you happen to work in the hospital based on NBC sitcoms, then you'll have the latest and greatest in trauma imaging systems. This is called a stat scan machine. It was invented for military just off the battlefield hospitals and Navy ships, where an injured soldier coming from the battlefield could be placed on a radiolucent gurney, and a C-arm could slide a fan beam from his feet to his head in 10 seconds and take an entire body AP view, and then the C-arm can twist to a lateral and slide back from his head to his feet, and 10 seconds later you get a full body lateral. So full body APN lateral inside 20 seconds. It's fantastic for that one x-ray, okay, of a severely injured individual where the trauma is so severe that it's whole body trauma. It's not just an ankle, and possibly multiple areas of trauma and life-threatening, and you need x-ray on your way to surgery. Yes, this machine is fantastic. However, this machine is a unitasker that probably starts around $500,000. So most x-ray techs can do trauma, and most x-ray techs do examine trauma with a conventional portable radiographic unit. And so we'll be utilizing the portable radiographic unit to practice in the lab, and I will show you some of the things you can do with a portable radiographic unit that you can't do with, I won't say you can't do them, it's just very, very difficult to do them with a conventional exam room. Okay. Now, preliminary considerations. Mobile fluoroscopy units may be used in fracture reduction. Immobilization devices are a necessity in trauma imaging. Okay. Trauma patients often can't hold the required position. And so sometimes you do take x-rays with the part immobilized and immobilizer artifacts present on the image receptor. It's more important to keep the body part still than it is to remove the artifact. Okay? And you might have remembered this from my intro lecture, if the part has been immobilized, you need to ask permission to remove the immobilizer before you do so for the sake of removing the artifact. It very well may be that the facility protocol of the place that you're at has a policy that you're not to remove the immobilizer until after the radiographic, preliminary radiographic trauma images have been obtained. Best practices in trauma radiography are speed, accuracy, and quality. We want to efficiently produce quality images in the shortest time possible. The way that we do that is we teach trauma positioning. We teach trauma techniques. We standardize how we do a cross-table ankle. We standardize how we do a cross-table knee. We standardize as many of the trauma views as we can and get our students familiar with doing routine views, but also doing trauma views. Okay? Accuracy, optimal image quality is still a standard. Minimum number of repeats is still a standard. So we just can't slap and shoot. We have to consider tube angle. We have to consider image receptor angle. And we have to consider fixation of the body part. Is the tube angle going to be standardized? No, that's going to be one of the things that you'll be able to adapt with, is tube angle. SID is one of the things you'll be able to adapt with. Image receptor alignment is something that you'll be able to adapt with. Okay? All of these changes to improve image quality. Okay? So trauma radiography is not just slapping and shooting, contrary to popular belief. Yes, that is the fastest, but it's not the most accurate. And there is still a minimum quality standard for radiography, for radiographs. Okay? You have to demonstrate an open joint space if you're imaging a joint. Doesn't matter if it's trauma, the joint space needs to be open. Okay? A lateral must be true lateral. You can't have an oblique. It's got to be true lateral. An AP needs to be a true AP. Okay? So take the time to adjust your tube, adjust your image receptor, and make, even though the patient's body part is lying in an oblique orientation, you have to get a true AP and you have to get a true lateral. Okay? Do not use the patient's condition as an excuse for poor quality images. Immobilization. You can't remove immobilization devices without a physician's order. I'd be comfortable with a verbal, but some of you may not. Some of you might want a written order that the immobilizer can be removed. Provide proper support and immobilization to reduce the risk of motion. Once you take the immobilizer off, it's your responsibility to not manipulate the part as much as possible, to retain the spirit of immobilization if you can. That is, keep the body part still. Remember, the only reason you're moving the immobilizer is to get rid of the metal artifact, the splint rods, if you will. Okay? Anticipation. Some injuries require follow-up procedures, like post-reduction. Knowing what to do increases appreciation for the radiographer's role in the emergency room. Okay? So, pneumothorax, trauma. Okay? Status post-car wreck, patient has a collapsed lung. So you take the initial radiograph and the ER physician is in the room and sees the collapsed lung, sees the pneumothorax, sees the atelectasis, And he looks over at the nurse and he says, I'm going to need a thoracostomy tube kit. And the nurse walks out of the room and she's heading over to the Pyxis or whatever the storage, whatever the storage room is, whatever thing that they have to keep track of how many thoracostomy tube kits they have. And she goes to retrieve a thoracostomy tube. Are you done? Can you just send the picture you took and leave the room? Are you done? The answer is no, you're not done. Unless your next x-ray is like right next door, I wouldn't leave. I would stay, because if the nurse is fetching the thoracostomy tube, that physician is about to insert a chest tube right there at the bedside. Okay, he's going to make a small incision between the 7th and 8th ribs, probably, and push that hose through and run that up into the pleural space. Okay, then he's going to apply suction. Hopefully, he's thinking clearly, and before he applies suction, he will ask you for another radiograph. Make sure you get a new order, because he is making a change. So make sure you get a new order, but don't leave the room. Okay, that's the anticipation. You know that if you see a collapsed lung, they're going to try to reinflate it with a chest tube. And so there's no reason to leave, because you have to take an x-ray of the chest tube. You see? And so anticipate, need, and follow up. If they reduce a shoulder, yeah, you're going to have to take post-reduction views of that shoulder. Pretty simple. If they reduce fractures in the ER, you know you're going to have to take a post-reduction series. Attention to detail. Pay attention to detail to the patient's condition, which could change at any time. Remember, this is also traumatic injury, so in between you thinking and hot dogging your way into a new orientation for the cassette and the x-ray tube and figuring out how to get the shot, quote unquote, your patient might be crashing the whole time. They might be drifting in and out. They might faint, especially if they've had a fracture. Typically fractures produce one of two responses, could be both, could be just one, whatever. People pass out when they have an actual fracture, and they also get nauseous and throw up. So be on guard for that, okay? Especially the nauseous and throwing up, okay? You don't want to be so engrossed in getting the x-ray that you suddenly feel warm vomit down the back of your neck, okay? So pay attention to your patient, pay attention to their condition, watch those monitors, right? Watch for them to go abnormal. There's a reason they hook them up to the monitors, guys. It's because they want to, they suspect that the patient's heart rate could get out of whack, or the blood pressure could get out of whack, could go too high, too low. The respiration rate could go crazy. They could start panting like a dog and getting real short of breath. Okay, there's a reason they're hooking them up to the monitors. So take a glance at the monitor every now and then. Okay, if the monitor starts alarming, yeah, you really should stop and figure out what the heck's going on with that. Know the protocol for the emergency room, for trauma, and know the scope of practice. Okay, because there's skilled activities and unskilled activities. And in the hectic pace of a trauma bay, with an ER physician right there in the room directing traffic and pointing at people and telling them what they need and, really directing the scene and the response, you have to know what you're allowed to do as an x-ray tech. Okay? I'm not saying say no to anybody, but what I'm saying is there's just certain things that everyone should know that you're not supposed to be doing. Like, for example, the respiratory therapist has got the embu bag with a full face mask, non-rebreather face mask, And what is the embu bag? It's that ball the blue football that they squeeze to make the patient breathe. Okay, so they've got the face mask over their nose and their mouth, and they're squeezing the ball, and then they let up and they say 1/1000 to themselves or maybe out loud, and then they squeeze the ball again. They're breathing for the patient. That's the job of the respiratory therapist. Okay, they should not be handing it off to you. Okay, that's a specialized skill set. You don't know how to maintain the airway. You don't know how to keep the chin elevated. You don't know how to keep the full face mask clamped to the patient's face. Okay, and maybe you don't know the timing, and maybe you don't know the signs to look for that the patient starts spontaneously breathing on their own. And so all of that's why we train respiratory therapists. So you really shouldn't take over the job of the respiratory therapist. Okay? Now, I have done that, but it was only for like one squeeze. Okay, because the respiratory therapist put an apron on, and I wanted the patient to take in a breath and hold it. They thought that I just needed them to suspend, and so they took a step back from the bag and said, "Okay, go shoot." Right? And without even thinking, rather than saying, "Well, I need a deep breath," I just reached down and squeezed the bag, and then I shot the x-ray because I needed the lungs fully inflated. Okay, I didn't really take over the job. The respiratory therapist was still there. I just did, one inspiration so I can get full lungs. Okay. Now, professionalism, adhere to the code of ethics. In trauma radiography, there's going to be a lot of judgment calls, a lot of does it need to be better, or is this good enough? Those type of things. Make sure that you're proud of the work that you submit. If you submit a radiograph, you should stand behind it. You should defend it. You should say, yeah, there's a reason that I shot this and turn this in. I know it looks a little off, but, and then you should have an explanation. So, I told you there was guidelines, there was protocols, there's a framework or like a set of parameters that we follow when we do trauma, because not all trauma exams are the same. Obviously, they're different body parts sometimes. So, but these principles remain the same. Principle number one, you move the body part as little as possible when you're doing the radiograph. Okay, so an elbow flexed 90 degrees, you can get a full series. You can get an AP, lateral, and coil methods. With the AP is going to take you 2 exposures, the bent elbow AP. The lateral is going to take an exposure, and then the coil method is 2 exposures. And so for 5 exposures, you can get the equivalent of an AP lateral and both obliques. Okay? And the elbow doesn't move out of 90 degrees of flexion for that. Okay? 4 different diagnostic views across 5 different images without moving the body part. That's the essence of trauma. Okay? So we move the body part as little as possible. Are we going to move it? Yeah, we probably are. Okay? But you should not be forcing the motion. The motion should be gentle and minimal. Okay? Maintain the relationship of the CR to the anatomy. That is, the anatomy projects onto the image receptor. Okay? But really, it's kind of like shadow puppets, remember? So the direction of the beam to the anatomy is a very specific relationship. The photons don't go through the joint spaces unless the joint space is the opening for the joint space is kind of facing back toward the X-ray tube. Okay, so the central ray and the anatomy, that relationship, however that manifests, like for example, everybody knows for an AP elbow, you extend the arm palm up, and then the X-ray enters like in the middle of the bend, like right underneath the bicep. There's a little depression right there where the bicep ends, right? Everybody knows that the central ray enters right there, okay? Now imagine that you can't straighten the arm. Well, you need to, with that modified AP, one for forearm, one for humerus, or distal humerus and proximal forearm, you really are maintaining the relationship of the central ray to the distal humerus during the distal humerus shot. And then you're maintaining the relationship of the central ray to the proximal forearm during that part of the exposure. So the relationship is maintained. It's just you're doing it in two different pieces. Okay? Like for example, for let's say a trauma oblique C-spine, that's a great one. We don't see those much anymore, but those are fantastic views. Now, in order to do an oblique C-spine, you got to use 15-degree tube angle toward the head, and then you need to rotate the patient's body 45 degrees, but you can't do that. So you have to invoke a transverse angle with the pivot button because the tube angle is already 15 degrees cephalad. You need a 45-degree transverse angle manifested with a pivot button. Okay? And then necessarily you can't shoot with a grid because you'll have grid cutoff. But you're maintaining the relationship of the central ray to the anatomy. The anatomy, you're not able to rotate the patient 45 degrees, so you have to rotate the tube and the beam 45 degrees. Okay? Now, at a minimum, for a trauma exam, like imagine the most mangled ankle or foot, you can't even recognize it. It's just like a wad of flesh. You don't know there's blood everywhere. You're not sure if the patient has all their skin. Muscle is sticking out. It's a mess. It looks like it's been through a meat grinder. You have no idea what a true AP is. You have no idea what a true lateral is. And so what you need to do is you need to take the mangled part and lay it onto a cassette and then shoot with a vertical X-ray beam like it was an AP, and then shoot a cross table like it's a lateral. That's two views at 90 degrees. The minimum radiographic exam, when the part has got so much trauma that you're having trouble figuring out if it is in the right position, shoot one vertically and then shoot another radiograph horizontally. Two views at 90 degrees at a minimum. All right, so your patient preparation, good communication, appropriate touch and eye contact. Trauma often causes anxiety. Yeah, it does. Okay. As far as your patients being nervous and fearful, yeah, the worst ones for that, checking that box each and every time, is the trauma patient. The trauma patient, they might actually be dying. So, or just in the most pain that they've ever had. Their neck might be broken. Okay. I x-rayed a man with a broken neck. I communicated to him. I said, it looks to me like you might have a broken neck. So we've got you on this backboard and we got you in this collar. You can wiggle your toes. That's actually a good neurologic sign. You need to keep your head and neck absolutely still, and you should be able to walk out of here in 6 weeks. Okay? If there's any shifting while you have this broken neck, you might be paralyzed from the neck down. And so I just laid it out to him. Okay? Was that diagnosis? Borderline. Yeah, probably the ethics council for the hospital probably would have had some words for me. Yeah. Might have been reprimanded if it had been overheard. But it was just me and this poor man who just broke his neck. And I didn't want him to have a bad outcome. And so I just broke it down for him. Okay? Check for potential artifacts. People that get into car wrecks, a lot of times they're wearing jewelry. No one plans on getting in a car. Oh, you know what? I think I've got a car wreck scheduled for 10 o'clock today. I'm late for that. No one schedules a car wreck. No one schedules trauma. And so your patient's going to show up with oodles and oodles of artifacts on. Okay? If you know you're going to the doctor, are you going to wear your jewelry? No, because you know the doctor is going to be a pain in the butt. The doctor's just going to make you take it off for the examination. And so you skip it. But if it's an unplanned emergency room visit, you had no idea you were going to end up in the emergency room that day. And neither does your patient. So understand their frame of reference and make sure you secure their personal effects and their valuables. Okay? Make sure you document the securing of their personal effects and valuables. Now, what's the best course of action? Well, it really depends on the procedure at your facility. We didn't really have a procedure at my facility until I brought it up. But our procedure was to have, if the patient had a friend or family member with them, that the friend or family member should take possession of the personal effects. Okay. Now, where we ran into trouble is some of the trauma patients didn't have friends or family members with them. And so the question, oh my God, you gotta be kidding me. I'm stopping until I can figure out when that's gonna end. Okay guys, I'm back. I think it was a leaf blower or some such thing. Anyway. Yeah, completely forgot where it was. Yeah, check the patient for potential artifacts. Oh yeah, I was describing our bad policy back in the day. If the patient doesn't have a friend or a family member to hand off to, we were to hand off to security. Okay. Either way, when you hand off stuff, make sure you're documenting it. Okay. Used to be we would have a paper request, so we documented it on the paper request. I'm going to tell you to get your patient's friend or family member to sign something saying that they took possession of these things. Get the security guard to document that they took possession of these things. Okay. A good facility will have a policy in place and possibly a documentation form for this process. So just be mindful of that as you're preparing the patient for the exam. You do have to get a hold of the valuables and make sure that those are secure. Okay. The last thing you want is, yes, you save the patient's life, but their 8-carat diamond earrings are missing. Yeah, that's a bad day. All right, IR collimated field size. Well, that's tricky. It's even more tricky because all the digital plates are way too big for trauma radiography. Okay, and that's actually one of the hindrances of the new DR plates is you can't tuck them into tiny areas like you could an 8x10 or a 10x12 cassette. So the collimated field size, that is how much light do you open up onto the collimators. They're basically the same as routine procedures, The trouble is the girth of the digital cassette sometimes prevents you from doing some of the trauma views easily. It takes a little bit of finesse to work with a big cassette to do some of these trauma views. Okay. If you're on CR, use the smallest IR available to you and the closest collimation that will demonstrate the anatomy. SID, you really don't mess with this very much. You can a little bit. You do know in general that larger SIDs make the anatomy smaller on the image receptor. Shorter SIDs make the anatomy magnified. This used to work out for like a trauma odontoid view. If the patient's in a collar and you have a portable machine, you can shoot with a 30 or a 25-inch SID, and it will have the effect of magnifying the center of the X-ray and everything else is spreading out to the side. So even a patient that minimally opens their mouth, you can get a decent odontoid with a shortened SID. Okay. By and large, though, you have to understand the adverse effects that are going to happen when you start manipulating the SID. First of all, your modern digital equipment, I don't think the portable machines, but the modern digital room won't let you shoot. It'll disable the exposure unless you're exactly at 40 inches or exactly at 72 inches. So, yeah, the portable machine, as far as I know, you can dream up any SID you want. Shorter SIDs are going to magnify the middle of the anatomy. Whatever you're actually aiming at is going to be magnified in the middle of the image receptor, and everything on the periphery is going to be spread further to the periphery. So I'll give you an example of what I mean. We'll take I don't know if we have a phantom. Yeah, we have a natural cadaver skull that I can take over, and I can show you. I don't think we have an odontoid, but we do have a natural cadaver. Might be able to show you some magnification effects and show you how it changes some of the things. So, when in doubt, just use a standard SID. ID markers are more important than ever. And a lot of our projections in trauma radiography are cross-table projections. That means vertical image receptors, so make sure your tape is fresh going into a trauma exam because your marker is going to need to stick to a vertical surface. Okay? Avoid using digital annotation, especially in the case of trauma, because it affects the legal status of the X-ray as a legal document. And trauma X-rays are more likely to be utilized in a lawsuit than run-of-the-mill routine X-rays. Not necessarily, but I mean, think traumatic injury, if it's not the patient's fault, if it's some other entity's fault, well, there might be a suit for medical damages. And so you don't want to have the claim denied because your radiograph wasn't up to the legal standards. So use your radiopaque markers, especially on trauma. There's also additional markers. They might call them bullets or arrows. They might have a roll of those in the control area. And there's also post-procedure annotation with some of the softwares where you can actually mark the wound. Now, in the digital age, it doesn't cost anything to make a duplicate. So I would send one unmarked if you were going to mark like the entrance wound. Let's say the person got stabbed, the knife was removed, and you want to indicate to the radiologist where the soft tissue knife wound was. You can do that with a digital annotation, but send him an unmarked copy first, him or her, an unmarked copy, make a duplicate of that, and then mark up the duplicate. That way the radiologist can pivot back to the unmarked one, because you might inadvertently superimpose something with your digital annotation. Radiation protection. No reason to forget the shield. Okay? Nothing's changed. Nothing has changed. It's just the patient has a severe injury. That's all. And so the guidelines that we use for routine radiography are the same as the guidelines for trauma radiography. You need to shield. You need to collimate close, and you need to use the correct technique so that you don't have to repeat. Okay. Immobilizers, sometimes they arrive with immobilizers. Immobilizers, as far as scope of practice, techs are not allowed to remove them. Now, all the time, I can remember clearly, I would go with a portable machine to a certain ER suite, right? Let's say it was bed 25. I'd roll over there. They got an immobilizer. I'd introduce myself. I'd ask them about the nature of their injury, take a little history, and then I would ask them about the immobilizer. Did they put that on themselves? Did the ambulance guys put that on? The EMT paramedic? How did their leg come to be immobilized? And typically the answer is the paramedic EMT put it on. So not always, but typically. If that's the case, you do need to excuse yourself from the patient. Go track down the ED physician and ask him. He's like, okay, you've got this knee x-ray and this tib fib ordered on Mr. Smith in bed 24, whatever it is I just said. They got a mobilizer on. Do you want me to shoot the radiographs with the immobilizer on? It's going to have an artifact posteriorly, so the AP views are going to be compromised and superimposed with steel rods over the anatomy that you're trying to see. So do you want me to shoot with the immobilizer on? Do you want me to take it off, shoot, and then put it back on? What do you want me to do? Okay. Usually it's up to the physician to make that judgment call. Okay. Some modern facilities, I don't know, it's been 10 years since I practiced. So there might be facilities out there where they have a strict policy and not even the physician can remove it. So decide to remove it. So it might be, if an immobilizer is placed, it doesn't get unplaced until you've had a review of preliminary radiographs. So, all right, documentation. Sometimes you're going to be deviating from standard positioning and standard protocol because of the nature of the patient's injury. Okay. If you're deviating from routine, make sure, first of all, that you're within your scope of practice to do so. Second of all, document what you did differently and why you did it differently. Right, table 13.1, diaphoresis, vomiting, lethargy, pale or bluish skin pallor, excessive thirst, paresthesia, that's the pins and needles sensation, eversion and foreshortening of the lower extremity, inability to rotate the foot medially. What do all these things have in common? These are signs of trauma. Okay, some of them are general signs of trauma. Vomiting is a dead giveaway for a broken bone. If they have an injured wrist or elbow and then they suddenly throw up, yeah, they have a broken wrist or elbow. That's right. Okay. With fractures, it's like bread and butter, baby. Okay. So be on guard if you think that they have a fracture. You should make note of where the garbage can is so that you can reach for it in a split second. Okay. Yes, we have them vomit into garbage cans all the time. Okay. The emesis basin, that's a joke. That's to shave with. Okay. Yeah, to shave your face. Right. That's the emesis basin will fill inside of half of a second. It's a joke, okay? Lethargy, weakness, sleepiness, sluggishness, pale or bluish skin pallor. That's probably a sign of shock. Diaphoresis is also probably a sign of shock. Excessive thirst might be something wrong with their blood sugar. Okay. Paresthesia might be a compressed nerve because it's the pins and needles sensation. Eversion and foreshortening of the lower extremity. Inability to rotate the foot medially. That is the classic sign for a hip fracture. Okay. So you should recognize all these as your patient's body is basically telling you that they are positive for fracture or the injury is real if these symptoms are manifesting. So pay attention and understand that you're not just there to get your x-rays, you're there to serve the patient. And if you see some of this stuff, respond appropriately. In particular, if you see the last one, do not frog their leg. Thank you. Image critique criteria. All right, image evaluation for trauma procedures, it's the same as for routine procedures. So what should you see on an AP wrist, or I'm sorry, a PA wrist? You should see open carpal spaces. You should see the radius and ulna. You should see the styloid processes. You should see up to the base of the fifth metacarpal bone. And so when you shoot a trauma wrist, yeah, open the collimation the same and include the same anatomy. Okay? Should the part be rotated? No. Okay? In fact, in a trauma case, your positioning and your image quality should actually be held to a higher standard. It is poor practice to accept lower quality images because of patient condition or difficulty of procedure. Okay? Hang on just a second. All right, he's got it. Sometimes radiography exams are hard, ladies and gentlemen. Sometimes they're difficult. You got to stop and think. Okay? You have to adapt and apply general principles that you've learned to a specific situation to solve a problem. Or as my favorite vascular surgeon, Dr. Chapman, used to say, if it was easy, they'd be doing it at Walmart. All right, lateral cervical spine, performed first, checked by physician before proceeding with other projections. That's actually dated. Like I mentioned in class, I think just this morning when I was going over the procedure syllabus, the standard of care now for clearing a cervical spine is no longer plain views. In the case of an MVA or fall or traumatic injury to the cervical spine, the neck, and or the head, if the patient's in a collar and on the backboard, you got to have a CT scan of that spine and that head first. And then look at those to determine whether or not the patient comes out of the collar and off of the backboard. Okay? So this used to be, when I started, this used to be the case. It used to be a plain film series of the C-spine was necessary first before you remove immobilizers. If we're doing a cross-table lateral cervical spine, it's horizontal beam, the patient's supine, you center to C4 in the mid-coronal plane. Okay? It's basically the same as a standing one, it's just the patient's lying down now. Okay? If the patient is awake and conscious and can assess their shoulders, you need to ask them if their shoulders are hurting. If the shoulders are not hurting, you should probably pull traction by affixing either gauze or bed sheet or what have you to the wrist And wearing a full body lead apron, pull on the wrists down toward the feet to achieve better separation of the shoulders with the cervical spine. Okay. If you don't pull traction on a recumbent cervical spine with cross-table lateral beam, you're only going to get down to about C5. Okay. If you're lucky, you're going to get C7, T1. Okay. But to even see C6 at half of C7, you have to pull traction on the shoulders when the patient's laying on their back. All right. Here we see a dislocation of C3, C4. Okay. C7 not demonstrated. Cervical thoracic is needed. All right. And we would actually call this injury a subluxation, where the top vertebrae, C3, is sliding over the superior edge of the vertebral body for the lower level, C4. Okay. Yeah, that is fragile. Yeah, you don't need to be doing manipulations. This patient needs to be in a collar until a fixation can be performed. All right. If you're doing a swimmer's projection, you need to shoot it just like a swimmer's. Okay. You're going to have trouble raising the arm if they're wearing a collar. You just are. Okay. Typically with the trauma swimmers and having trouble raising the arm closest to the image receptor, you usually shoot with about a 2 degree caudal angle through C7T1. Okay? And that'll help you separate the shoulders just a little bit more. Okay? So there we go. We're centering for C7T1. The one shoulder is elevated, the other shoulder is relaxed. Ask your patient if they can move their arms without pain before you place them in this position. You can also apply traction in opposite directions here to create more separation. So our cervical thoracic swimmers, the anterior edge of the vertebral bodies, that's the bare minimum for what we need. We would like to see open intervertebral disc spaces. So remember that tube angle? I said angle about 2 to 3 degrees. If you do more than that, you're going to start closing the disc spaces off. And then they're going to look like they're pathologic and collapsed. So be careful with that. We do need a true lateral or close to a true lateral cervical thoracic spine. Okay. Vertebral body of C7T1. Intervertebral disc space should be in the middle of the radiograph. Okay. Elevated arm posterior, yeah, that's fine for this one, for a recumbent one. Apiaxial oblique cervical spine. This is a trauma oblique. You're actually going to shift, you're going to do this tabletop because otherwise you'll get grid cutoff. You're going to rest the patient's head and neck on the image receptor, but it's going to be off center, okay? So the tube angle is going to come in at a 45 degree transverse angle using the pivot button, okay? So why are you not using the tube angle button? Well, the tube angle is being employed for that 15 degree cephalad angle to open up the disc spaces and the intervertebral foramen. So the only other way to angle the tube in the transverse plane would be to use the pivot button, right? And so this is not a detent procedure, this is a tabletop procedure. And you can't use a grid because you will, with the transverse angle of the X-ray beam, you will get grid cutoff. Okay? And so you shoot this non-grid 45 degree central ray to the body part and the image receptor. Notice this obeys one of the rules. If we have to sacrifice the orientation of the anatomy to one of the external objects, well, we're sacrificing its orientation to the image receptor while we preserve the orientation of the central ray to the anatomy, okay? Because the intervertebral foramen opens because the x-rays are traveling right down it, okay? So if you come in at a different angle, it's not going to work, okay? The image receptor should be perpendicular to the central ray, but we can't make that work in this scenario. And so we just leave it horizontal. And what happens is we get transverse elongation of body parts. So the cervical vertebrae stretch out from left to right. And so do the intervertebral foramen. There you go. That's what it looks like. You see how it looks elongated in the transverse plane? This is how you tell you've done a trauma oblique rather than a conventional oblique. It's because the vertebrae are distorted in elongation. Trauma lateral lumbar spine, it's same as you do, you're just shooting horizontally. It's the same as if they were standing or if they were laying on the table. The central ray is going to enter at the level of the iliac crest on the hip that's furthest from the image receptor. And then it's going to pass through the other hip, and then it's going to impact the image receptor. Okay. The big thing with the patient laying down, you got to get those arms up. Okay. The patient can't support their arms like this. You can't leave them down on their side. You do have to get them, at a minimum, they have to cross their arms over their chest. But the better posture, if they're capable, is raising their arms all the way above their head. That way you're certain that there's no anatomy obscuring the lateral lumbar spine and the lateral T-spine. Okay. So here's our lateral lumbar spine, and we have a fracture and dislocation again. Okay. Looks like that's T12 has subluxed, and in doing so, L1 has got an avulsion fracture at the anterior superior edge of the vertebral body of L1. Notice the patient's underwire bra artifact. While it's not critical to the lumbar spine, it may affect visualization of the thoracic spine, particularly in the AP view. Okay. So now, will you be able to remove that? Hard to say. Okay. I did have to cut a bra off, I remember, at least one time in my career. So just, the nurses have trauma scissors. If you don't have a pair of your own, run over to the ED, tell them you need trauma scissors, tell them you need to cut the bra off of your trauma patient to get them off the backboard. All right, the chest x-ray needed to demonstrate air fluid levels. If air fluid levels are suspected, use a dorsal decubitus position. Okay, so for a trauma chest radiography, now most of the time it's an AP recumbent with no tube angle for a true trauma. But if there is a hematoma, you might ask the ER physician if they would like a follow-up cross-table projection to assess the size of the hematoma or the fluid level. If the patient's condition permits, lateral decubitus positions lying on the affected side will also show an air fluid level. But again, you got to be sure that the patient can tolerate that. Okay? If the patient's laying flat on their back unconscious, just shoot a dorsal decubitus. Okay? Supine position used if general survey image of the chest is desired. If they're looking for acute rib fracture, hematoma, pneumothorax, associated atelectasis. They're just trying to assess if the lungs are inflated, if they have pulmonary markings, any kind of survey, gross pathology. Yeah, AP supine, no tube angle. So you will need lifting help if the patient's unconscious and they have someone breathing for them. You'll need that respiratory therapist to stay right there and hold the patient's breath on full inspiration. That's a squeeze of the blue football and hold that squeeze in. Top of the image receptor, again, 1.5 inches to 2 inches above the shoulders. You can actually cut it a little bit closer than that because when patients are laying on their back, their shoulders tend to rise up a little bit relative to the thorax. So you can bring it in to just 1 inch above the shoulder typically. Arms abducted. If your patient's unconscious, just make sure their arms are down by their side. If your patient is conscious, make sure you give them the instruction to keep their arms by their side. Okay. Mid-coronal plane parallel to the IR, so check to make sure once you have them placed on the backboard or on the cassette. First of all, make sure your cassette's not going to get crushed. Some of the DR cassettes are sensitive to how much weight you can put on them. But once you have the cassette centered, and I'll show you how to check the 4 corners for trauma placement. Make sure the patient's square, they're not rotated. The shoulders are equidistant from the table surface or the image receptor surface, and the hips are also equidistant from the image receptor surface. Okay. Since you are doing an AP, you're inadvertently going to magnify the heart. So you should raise the X-ray tube up as far as it will go, or back as far as it'll go, or what have you, so that you get close to a 72-inch SID, as close as you can, given the limitations of the equipment in the room. Okay. All right, this one, let's see if this one's going to work. No, it is not. I'm probably going to play this one for you live. This is actually on flail chest. I'll include it in the trauma unit as a standalone video so you can see what flail chest is all about. Okay. Pelvis. Pelvis fractures. If the pelvis is fractured, there's a high risk of hemorrhage. Okay. So watch out for low blood volume and hypovolemic shock if your patient has a pelvis fracture. Obtain lifting help for IR placement again if X-ray transfer to the X-ray table is not possible. Typically with a pelvis fracture, you just want to shoot it portably and try to get the whole thing on there. Okay. Radius center, same as you always do. 2 inches superior to the pubic symphysis, 2 inches inferior to the ASIS at the mid-sagittal plane. Make sure the pelvis is square, not rotated, to the best of your ability. Don't move a body part more than you have to. Okay. Remember, you still have that powerful weapon called tube angle. You can, with a portable machine, you can do just an oblique tube angle to make an oblique pelvis look like an AP pelvis. Okay. Here's our trauma pelvis. Looks like there's a fracture right along the SI joint, and there's a separation of the pubic bones. Okay, so that's a fibrocartilage joint, the pubic symphysis. That looks like it's torn. Notice, I think there's a zipper artifact in the right SI joint. Sometimes, you got to weigh the importance of removing the artifact. In the ideal situation, all artifacts would be removed. Okay. Upper and lower limbs. Hang on just a second. All right, sorry about that, guys. Upper and lower limbs, obtain lifting help. You should, if you suspect a fracture, support on both sides of the fracture. Okay. It says at both joints, but you see, like a Colles fracture, you should be lifting the hand and the mid forearm, and it should be a combined motion. And I'll demonstrate that to you as I show you how to position some of these trauma. 2 projections at 90 degrees from each other required. Do not attempt to rotate severely injured limbs for true positions. Okay? And so you can use tube angle in the transverse plane to make an oblique body part look true AP, but don't rotate the patient's body part. Okay? Other imaging in trauma, CT is extensively used for trauma patients. And here we see a fractured cervical spine. The lamina is fractured as well as the vertebral body. Okay, looks like part of the transverse process too. Right, and so CT is the gold standard for trauma radiography of the neck, the chest, the head, basically everything. Okay. We couldn't do as much with trauma radiography if we didn't have the CT scanner. So it is a vital tool, probably even better than plain films in some scenarios. Well, an ankle, no. You can diagnose fractured ankle with plain films still. Fractured elbow, yeah, still plain films. Fractured hip, yeah, you can diagnose with plain films, but you get a much better idea of what's going on with a CT scan of the pelvis. All right, trauma pathology. I think this is just my radiographs. All right, so first up, quiz, we have a transverse fracture of the distal radius. The ulnar styloid process is avulsed. And according to radiograph B, the hand and the carpal bones are posteriorly dislocated. So what do we call this fracture, right? When 3 things are true. Yes, this is called a Colles fracture. I hope you got that right. This is a Colles fracture. Okay, Colles fracture, 2 views at 90 degrees are adequate. Okay, that's all they need to confirm for a Colles fracture. A transverse fracture of the radius, that's confirmed in picture A. Ulnar styloid process is avulsed. That's also confirmed in picture A. Picture B, the lateral, confirms posterior dislocation of the distal anatomy. The carpal bones and the bones of the hand, the entire hand, is posterior to the forearm now. Okay, from its normal alignment. So this is a posterior displacement with fracture. This is a Colles fracture. Okay. Occult fracture of the elbow. What do you see there? Yeah, you see a sailboat, don't you? Yeah. It's like, ooh, sail sign. You should have seen that even before I asked you, before I prompted you. You should have been like, oh, that's a sailboat. That's the sail sign. Yeah, they do have a fracture. I don't see the fracture myself. Typically, your fractures here with the occult sign is either radial head fracture or possibly distal humerus fracture. Okay. But those fat pads are pushed out of the fossas by pooling hematomas. And we went through that in rad procedures 1. Okay. What fracture is that? That is the base of that's the tuberosity at the base of the 5th metatarsal, and that's another avulsion fracture. What does avulsion mean? It means chipping. So the bone is chipped right there. That's a Jones fracture. Derrick Henry suffered from this, I think that was 2 years ago now. Okay. What fracture is this? That looks like a fracture of C2 at the pedicle lamina junction. Maybe the pedicles of C2 have broken away, and anterior displacement of the body of C2 and C1 in the head. This, ladies and gentlemen, is a hangman's fracture. What pathology do we see here indicated by the black arrows? This is a collapsing lung for reason of pneumothorax. So there's a cause and effect relationship here. The pathology is atelectasis or collapsing lung. The root cause is another pathology called pneumothorax. So what are the black arrows indicating? The black arrows are indicating the visceral pleura membrane around the lung. Okay, it's not up against the chest wall. You're starting to amass an air volume in the pleural cavity. That's what a pneumothorax is. Okay, but atelectasis is separate from that. Atelectasis is not a synonym for pneumothorax. It's an effect of pneumothorax. Atelectasis is collapsed lung. Collapsed lung can have several root causes. Pneumothorax, hemothorax, pneumonia, pulmonary edema, all those things can cause collapsed lung. Okay. What pathology? Okay, so clearly you might notice that the tibial plateau is not articulating with the femoral condyles like it's supposed to be. Okay, and so we have a cross table here. Now, what's the nomenclature rule for dislocations and displacements? Well, what was it for the Colles fracture? Didn't I say the carpal bones and the bones of the hand had shifted posteriorly? That's the distal anatomy. So, again, for just a refresh on the rule, you describe dislocations and displacements as if the proximal anatomy has held still and the distal anatomy has shifted. And so the distal anatomy between the femur and the tibia is the tibia. It looks like the tibia has displaced or dislocated anteriorly. So this is an anterior dislocation of the knee. Okay. And someone will say, well, why don't we say that it's a posterior dislocation of the distal femur? Well, because that's not the nomenclature rule. The way that we name this is always the distal anatomy seems to be the one that is shifted. Right, with pathology, now this is it looks like a Waters projection. I don't think you've had the skull unit yet, and so you don't know what this sign is. But it's actually a sign for an orbital blowout fracture. We got a little teardrop in the left maxillary sinus, okay? And so right underneath the orbit on the left side, there's an extra couple lines there that you don't see on the right maxillary sinus. And those extra lines, that's the fat pad that your eyeball rests on, is dripping down into the fracture and hanging in the middle of the maxillary sinus, very much like a tear that refuses to fall. Okay, so the teardrop sign is the sign of an orbital blowout fracture. You need a modified Waters projection, which is what this is, in order to effectively diagnose orbital blowout fracture. I will cover this again in the skull unit. Have no fear. It's actually a facial bones projection. Okay. What pathology do we see here? Well, this one is tricky, but I need you to look at the right rib cage and see if you see anything kind of weird. Yeah, 1, 2, 3, 4, 5. The sixth rib. Look at that sixth rib. See how it kind of caves in right there in the axillary region? So we have a rib fracture of the sixth rib because the sixth rib is not running in the same line as the rib above it and the rib below it. It looks like it's caved in. So it's been displaced. Yeah. The lung, the nice news is the lung is fully inflated. But that is a fracture of the sixth rib on the right side. Okay. No, I cannot see the fracture line. I just see that the rib has changed course compared to its counterparts. Okay. What pathology do we have here? Yeah, sulcus sign. Okay. So this is AP supine pediatric chest x-ray. Okay. They have a chest tube placed on the right side. You guys see how the costophrenic angle is extremely long there? Well, that's because that's not the costophrenic angle. That is what's called a false foot or a pneumothorax. So when you have a pneumothorax but you're laying on your back, it doesn't manifest in the apex of your lung anymore. It actually goes to the costophrenic angle and expands it. So that air is pushing the liver away from the rib cage, which is that's a pretty good feat in itself. The chest tube needs to be positioned differently, or the patient needs to be turned, because if the chest tube is applying suction, it's ineffective all the way up there in the apex of the lung. The air bubble is down by the base of the lung and the costophrenic angle on the right side. This is called a sulcus sign or a false foot sign. It only manifests for pneumothorax when the patient is supine for the radiograph. Okay? You often see this in children. This is how you'll see a pneumothorax show up in kids rather than in the apical regions. Okay. What pathology do we have here? Well, you can see there's a lot of gas in the colon and the stomach, but there's a lot of attenuation. Look, there's a liver up there, or at least we think it's the liver. But look at all the attenuation through the pelvis on the right side. What you're viewing here is a massive hematoma in the peritoneum. The liver shows up medium gray because it's so vascular and it's carrying so much blood. Okay, it's the iron in the hemoglobin that is actually attenuating the X-ray in the liver and making it show up as like a medium gray blob. It's not as effective as because the tissue isn't as dense as bone matrix, but iron's got a pretty good atomic number. I think it's like 42 or something like that. Don't quote me on that. You can look that up yourself. Okay, but blood pooling will attenuate. Okay, so hematomas will show up as radiopaque objects. And this looks like the patient has a hematoma filling the pelvis and the right side of the abdomen. And it also is displacing the colon and the small bowel over to the left side. That's why all the air is over there. You're actually pushing, the hematoma is taking up room, and so it's pushing bowel loops out of the way to take up the space of the basically the right lower quadrant. Okay. What fracture is this? So this is a cross table, but we have a lateral. There is a transverse fracture of the radius, and the distal anatomy is anteriorly displaced this time. And so this is not a Colles, this is a reverse Colles, which is called a Smith's fracture. Okay, it's pretty good lateral for considering the patient's condition. Okay. And then what fracture do we have here? You're going to find the fracture in the distal radius. This is called a torus or a buccal fracture. You see, it looks like the bone is growing a pimple, like superimposed with the distal ulna right there. See that little bump or bubble? Kind of looks like a pimple or a blemish. That's actually the bony cortex is bulged out because the radius has collapsed on itself right there. And so it's kind of like a crushing injury to the end of the radius and a buckling of the cortical wall of the diastasis of the radius. Torus or buccal fractures are more common in pediatric patients, of which this patient, how do I know this is a pediatric patient? Well, he still has epiphyseal plates at his elbow. His olecranon still has an epiphyseal plate, and so does his radial head. So yeah, he's probably a young teenager. What fracture here? This is an oblique hand, but it looks like there is a fracture to the base of the first metatarsal. So the question is, was that a boxer's or a Bennett's? Which it's a Bennett's fracture. That's right. Okay. The patient is rolled just a little bit too steep, but don't repeat it because we have evidence of a Bennett's fracture. So it's a good radiograph. It actually provides nice isolation of the first metatarsal, or metacarpal rather. Oh, Lord. First metacarpal is nicely separated from the rest of the anatomy, no superimposition, and you can clearly see that there's a little piece that is chipped off of the base of the first metacarpal bone. Okay, that's all I got, guys. Trauma is dramatic change in the patient's health and well-being. So you need to be vigilant for deterioration of condition. They could go into shock at any time. They could pass out on you. They could vomit on you. Okay? They could have diaphoresis, cool, clammy skin. Okay? Trauma views are just adaptations of conventional views. You're not able to rotate the body part or manipulate the body part, so you have to manipulate the position of the tube and the image receptor to accommodate and still get the preferred views. Okay? The key relationship that you must not sacrifice is the relationship of the central ray to the anatomy. Okay? Central ray is directed to open up the anatomy and display it with minimal superimposition for each and every view. Okay? And so you need to preserve that, otherwise you start closing off joint spaces and elongating or foreshortening certain features of the anatomy. Okay? Try to position the tube so it aligns with the anatomy just the same as it would in a routine study. So some of you will work with a Lodax machine. You have to come back and tell me about it. Okay. What was the Lodax machine? That was the one featured in Gray's Anatomy at the front of the lecture. The Swift scan machine that does the AP and the lateral in about 20 seconds. Okay. It might be because it was such an awful unitasker, you might not see it outside of a military application, but some trauma hospital somewhere has invested in that thing. So hopefully you find one and you email me back or come back and tell me and just let me know how it was to shoot the Lodax machine, the AP and lateral in 20 seconds. Full body AP and lateral. It is an impressive machine. So anyway, that's it for trauma radiography recorded lecture. We're going to have a lab where I'm going to go through. We've already covered some trauma views, but I'm going to cover trauma views extensively in lab and go through like some of my strategies that I invoked when I was a technologist, things that worked for me that should work for you. All right. I'll see you guys after my vacation. Well, I'll see you tomorrow. And then I'll see you after my vacation. Y'all take care. Have a good evening.